So I would be talking to you about practical tips in the management of fungal keratitis, and we have talked about it at various platforms and at various fora. But we would be talking mainly about the practical way in which it can be managed. There are no financial or proprietary interest in any of the products mentioned in this presentation, and it does become important for us because almost half our cases are fungal in etiology. It is important again where you're sitting. So if you're in the northwest India, aspergillus is most common, and if you're in the southeast India, then it is Fusarium which is most common. And of course, we are all aware of the clinical features which are redness, pain, diminution of vision, but it tends to be a little more indolent, as Manisha also pointed out in her presentation. And then you have classical picture of dry, thick, raised texture with feathery margins, satellite lesions, endothelial plaques, and fixed hypopyon and abscess. And of course, if you have pigmentation such as this, that means it is most likely because of dematious fungi. And Fusarium tends to have a more severe course, and if it does get treated, then you see that the pigment is disappearing. For dematious fungi, in the morning I had a question. The drug of choice is again netamycin. Then 10% KOH was shown long back that it has sensitivity of 91 to 99%, and you do send cultures on Sebrot's dextrozagar in all those cases, which in fact are culture negative, and you still think that they are fungal keratitis. These can be sent for PCR or for confocal microscopy, and if you pick up hyphae in that, antifungal agents could be started. Now, this was thesis which was done at our center, spectral domain anterior segment OCT in fungal keratitis, where we looked at the activity of fungal keratitis. So actually, you can, on the anterior segment OCT itself, you can pick up the features, and we classified as to what the active features on anterior segment OCT are, and clinically correlated with the clinical picture. So 5% netamycin is the drug of choice hourly during the daytime, 2 hourly at bedtime, and round the clock for the initial 3 to 4 days. And you have to taper only. In fact, you have to decrease the dose after 4 to 7 days if it is responding. If it is not, then you have to add 1% voriconazole, and the therapy classically lasts for 3 to 4 weeks. And these are some of the cases of Fusarium keratitis on topical netamycin. And there is a limitation for the commercially available preparations: poor ocular penetration, poor bioavailability, and toxicity of the currently available drugs. So the MUT1 trial did tell us that voriconazole should not be used as a monotherapy in cases of filamentous keratitis. It did not look at the role of combination therapy in cases of fungal keratitis. And although systemic antifungals were advocated for large ulcers, deep ulcers, scleritis, post-PK keratitis, and ophthalmitis, and voriconazole as well as ketoconazole could be given in 200 milligrams BD, but MUT2 did tell us that systemic has limited role to play. So this is just to show a case. Sometimes when topical netamycin 5% doesn't work, what do? So you add either systemic ketoconazole if the patient is not able to afford systemic voriconazole, or you can add voriconazole if the patient is able to afford it. And this is just to show how a case of fungal tunnel keratitis responded to topical and systemic antifungal therapy. Now, Mattu also did also point out the finding that Fusarium keratitis may benefit from the additional role of oral voriconazole to topical netamycin. And so we did do a randomized control study where we looked at oral voriconazole versus oral ketoconazole. And in terms of duration of resolution of the infiltrates, we found that there was no difference, which is good because you can give ketoconazole or voriconazole depending upon the affordability of the patient. But in terms of the tear film and the serum concentrations, at all points in time, the voriconazole was found to be higher as compared to ketoconazole. So this was possibly a theoretical advantage of voriconazole because it did not clinically translate into to the results, and you never know if your numbers were more, probably it would. So this is the paper that we published. Then we came to targeted drug delivery because there were cases where topical doesn't work, systemic doesn't work. You add two topical and systemic, it doesn't work. Then what do? So initially, amphotericin B, when these targeted drug therapy was started, came into vogue, 5 to 7.5 microgram per 0.1 ml, and later on, voriconazole became the fashion of the day with 50 to 100 microgram per 0.1 ml. And this is just to show how intracameral amphotericin B did help in a case. And of course, there can be problems in the form of anterior chamber inflammation, cataract, pain, and theoretically there could be secondary infection, although there are no studies to say so. Then we could give intrastomal injections in deep mycotic keratitis, non-perforated corneal ulcers, not responding to conventional topical and systemic antifungal therapy for 4 weeks. And these are some of the anecdotal reports. And why did we start it in our center? The reason was this case. This was the very first case which came to us. And this was in fact referred from outside, was on all medications and did not respond. And we were about to take this case for a therapeutic graft, and we said, why not try intrastomal injections? And we tried intrastomal injections, and the response was so dramatic that we were encouraged to use this mode of therapy in our armamentarium of the uh, care that we do for microbial keratitis and especially fungal keratitis. So this is what we published, the first three case reports, and then subsequently there are, if you see the anecdotal case reports, there are there, where intrastomal injections do help. I think it is a matter of timing, and it is also a matter of case selection. And this was a randomized controlled trial which helped us to understand that to topical uh, to topical netamycin, if you add topical voriconazole, then the results are better than if only topical netamycin is there. And so combination therapy probably has a greater role to play than a single drug therapy for fungal keratitis. And intrastromal voriconazole in this cohort did not show a significant difference when it was added to the topical netamycin therapy. And this is just to show how it is done. There is no big deal about it. You just wash the anterior segment, the anterior chamber with the antifungal drug, and then give intrastomal injections, which are given with a 30 gauge needle in an area which is relatively clear, where it is not so thinned out, and the reflex is very much like the reflex of a phaco wound hydration. And this is just to show the cases from that study: topical netamycin and topical voriconazole, topical netamycin and intrastomal voriconazole. And vascularization, when both the groups were compared, was found to be comparable. So this is what we proposed, and I must give credit to Professor Tityal for this, because when I was doing this presentation about few years ago, he said you should come out with the algorithm because people don't know what to start when. So this was in fact conceived at that time. So if you have a case of fungal keratitis and the involvement is less than 5 millimeters in size, with less than two-thirds trauma, topical netamycin can be started. If there is no response, you add topical voriconazole to it. Again, if it is more than two-thirds stroma, more than 5 millimeters in size, systemic can be started. If there is no, and topical both can be started. And if there is no response to it, then targeted therapy can be given in the form of intracamerals or intrastromals or both, depending upon where the lesion is. And of course, if it doesn't respond here, that is when the ulcer size is less, then we can always shift to this column on the right side. And this is the paper we published based on a prospective cohort of 223 patients, and then subsequently published this with the help of all our departments: the ocular microbiology, the ocular pharmacology, and the various people who worked on this. So when we gave medical therapy alone, the success rate was 74%. When we added intrastromal, then the success rate it became higher, and that is why we called it the TST protocol, or the topical, systemic, and the targeted protocol for fungal keratitis. Now, sometimes you may have to resort to more than one. You have to do a multi-prong attack. This was a case of therapeutic keratoplasty where again reinfection occurred, and then again intrastomal injection was given. So sometimes one weapon doesn't work. It has to be more than one, and this I've talked about. And we are now doing a clinical study with netasol, where we've combined it with the polymer to make it soluble. And if you look at the pharmacokinetics, they are better than suspension of netamycin, which is currently available commercially. And this is just to show a case again, post-LASIK Fusarium keratitis with intrastromal netasol that we did, and it responded to therapy completely. This is how the healing of a corneal ulcer should be. With every passage of time, the epithelialization occurs and a faint corneal scar forms. And therapeutic keratoplasty would be dealt by Professor Titial. He would be talking to you about details. So to conclude, geographical variation does occur in cases of fungal keratitis. Natamycin is the first drug of choice. You may add voriconazole if there's no response. Systemic voriconazole, I believe, does have a role to play, although many would feel otherwise. Targeted therapy is useful in recalcitrant cases, and surgical management has to be resorted to for cases which are not amenable to medical therapy and injections. And I would like to thank everybody who's worked on the several studies that we have published, while embarking on our journey on fungal keratitis. And thank you for your kind attention.